Hello, today we will be talking about patient application of aerosol delivery device. I encourage you to visit the AARC website and look at the clinical practice guidelines regarding selection of aerosol delivery device. The first question we'll discuss: what percentage of patients and healthcare professionals is believed to use an MDI incorrectly? The answer here is up to 2/3 of people use the device incorrectly. This leaves a lot of room for us to improve patients' technique by continual coaching. The most important thing, however, is for us to give patients an adequate explanation and education on the device the first time it's used, because it's kind of that saying, old habits are hard to get rid of, or whatever that is. Because once we learn something one way, it's really hard to change the way we use an MDI if we are using it incorrectly. So what percent of the drug in an MDI is actually deposited in the lung? This can vary a lot also depending on the technique. Again, we say somewhere between 10 to 15% under optimal circumstances, but the variability is based on the technique and the technique including the patient's breathing pattern. Again, with an MDI, we're looking for a slow, deep breath in with a breath hold. Well, the more we can slow down that airflow and the longer somebody can breathe in and then do an adequate breath hold, that will determine the amount of medication that's administered, as well as when the MDI is activated. If the patient puts it up to their mouth and puts it in their mouth, that's going to reduce deposition. If they go ahead and move it out 4 centimeters from their mouth, but have difficulty coordinating activation with the breath in, that will also create some variability in the dose delivered. Because if they activate the chamber and then begin to breathe in, more of that drug is deposited within the oral pharyngeal cavity. The other variability then becomes that breath hold, because the breath hold allows for a time of no flow, and when there's no flow, then those particles have time to fall out of suspension. The aerosolized particles, that is, can fall out of suspension and land on the airways of the smooth muscle, in the smooth muscle where we want the medication to take effect. When should you use a spacer? Definitely they are more recommended with corticosteroids as a way to decrease the oral deposition of the medication. Again, if we're delivering a steroid, we're going to have the patient rinse their mouth, but we also will use a spacer for almost every patient that we are administering an MDI within the hospital, because we find it improves deposition of the particles. How does a breathing pattern differ with or without a spacer when administering a DPI? Think about that for a minute. And remember, with a spacer, we're going to activate the chamber and then take a slow, deep breath in with a breath hold. With a spacer, we can also take several breaths to acquire the medication. Without a spacer, we activate the canister, that is, after the breath has begun. So we start to breathe in and then activate the medication. Again, slow, deep breath in, but we only have one breath to be able to get that medication. What patients cannot use a DPI? Generally, we're going to say children under 5 and those patients unable to generate a high airflow. So during an acute episode, patients may not be able to use the DPI effectively. They may also not work under very high humidity environments. So again, we think children under 5 probably cannot generate the airflow. Some 5-year-olds may be able to, or 4-year-olds, but we're going to check that. In general, we say probably that won't work. And again, DPIs are a maintenance medication, so they aren't used for acute drug delivery for active bronchoconstriction. They're more a preventative medication. What potential problems may exist when you deliver a small volume nebulizer via a mask? Well, if the patient is allowed to with a mask and the patient inhales through the nose, most of the medication will be deposited in the upper airway and not the lung. It's important when you're using a mask, if you've determined that they have difficulty holding the mouthpiece within their mouth, it's important to instruct the patient to breathe through their mouth, even though they have the opportunity to breathe through their nose only. Remember, the anatomy of the nasal cavity has so many folds within those turbinates that we will have a lot of the medication deposited in the nasal region. So now we have a typo. This should just say Bob the bloater is an alert, cooperative 52-year-old male who was recently diagnosed with chronic bronchitis. He quit smoking 6 months ago. He had a 60-pack year history, but still has respiratory symptoms. He just had a PFT, and they are recommending Combivent. What delivery method could you recommend? Okay, so for this one, we would recommend MDI. In part, if you look at the clinical practice guidelines, one of the requirements is knowing the form that the medication comes in. Combivent only comes in MDI form. If we needed to give a nebulizer, we would need to reorder the medication for DuoNeb. In this case, for this patient, he's alert, he's cooperative, he's 52 years old. He's going to be able to most likely perform an MDI adequately. We may want to include a spacer or holding chamber. We'd want him to be able to demonstrate proper technique using the MDI. We have another patient, Randy. He comes to ER in acute respiratory distress. He was diagnosed with status asthmaticus. He's a 27-year-old male who has wheezing, respiratory rate of 24, heart rate of 106, SpO2 of 92. His peak expiratory flow rate is 150 liters a minute, and that was after 4 puffs of albuterol from an MDI. What would we recommend for this patient? We have 2 options. We could repeat the 4 puffs of albuterol, or we may recommend switching to a small volume neb, and that would be because his peak flow rates are fairly low. So he has a high amount of airway obstruction, making it difficult to perform adequate MDI use. With a high respiratory rate, in addition, I should say, to that high respiratory rate. So at this point, we have the option of an MDI, but probably a better recommendation would be to switch to a small volume nebulizer. So now we're asked to deliver a bronchodilator to a patient in the neuro unit. When you arrive, the patient's obtunded. Breath sounds reveal scattered bronchi and wheezing. What should we do? Well, first it's important to know what obtunded means. That means they're not responding to stimuli. So we can't give verbal orders. They're not alert and cooperative. In this case, if we have wheezing and we need to give a bronchodilator therapy or aerosol medication, delivery suggestion would probably be to use a small volume nebulizer. As we're assessing this patient, we'd also want to determine whether or not the patient could use a mouthpiece or if we should give a mask treatment. Most likely, if they're unable to follow instructions, a mask treatment would be more appropriate. Continue to review the clinical practice guidelines and think of other patient scenarios that would sway you one way or the other using the different delivery devices.